Okay, good afternoon, everybody. We're getting started just a little bit late. As I was looking around to make sure we had a quorum, I forgot that we have people joining us on Zoom. So welcome to everybody that is joining us on Zoom. We're glad to have you. Unfortunately, what do we do about rules and things about this? We're going to have to bear with us. This is our first time to go this way. Our first order of business, as always, is first to introduce when we have one new member, Representative Barton. Representative Barton, wave and say hi to everybody. So we're glad to have you. That's the only person we got. So we kept our large committee a little bit more compact with just one person joining us. So I'm glad for that. If you will go to your packets and look in the packets for the rules, that will be the next order of business. And for those of you that don't have a packet that are coming in by Zoom, you should have them by email. Okay, everybody's got them? Okay. There has only been one change. The quorum's still 11, but number 14 is new. So if everybody would look at number 14. And really, this is just to help us get set up and know who's going to be coming in by Zoom and give the people in, what do they call that department?
Your office.
Well, just my office sets it up.
Yeah,
I thought we had to use technology too.
Media services.
Media services. It gives them time to be prepared since we are now using both Zoom and in-person meetings. Yes?
As we get into the last third of the session, there'll be meetings that'll be called less than 24
Hours.
Yes,
Yeah.
what do you do in that instance?
Well, in that instance, we'll deal with it. And if you come in by Zoom, we're not going to keep anybody out in the last of session when we do meet more frequently. It's on the call of the chair. And, you know, when it's really like it does always at the end of session, I'm not going to keep somebody coming in from Zoom just because they didn't give us 24 hours notice. But now, until we get to that point, although we're moving fast to that point of moving on down and eating up days, has everybody had time to look at the rules? Hey, Representative Howard. Okay. Representative Hogan.
I'll make a motion to adopt the rules.
Okay, you're recognized for that. I've got a motion, a second to adopt the rules. Is there any discussion? If you're on Zoom and you want to discuss, hold your hand up. Michael will be looking for you. Okay, hearing no discussion. Everyone in favor, say aye. Aye. Anyone opposed? No. Or I guess, have you got them on speaker?
We should be able to hear them.
We should be able to hear them. And if we can't, you can always do a thumbs down on an issue and we'll watch for it. Is that okay? We got it. Okay, that takes care of the rules. Okay, first of all, when we thought we'd be moving a little bit faster, I had told people that Quest Diagnostic could come and do a brief update on us on all things about COVID. So do we have someone here from Quest? Oh, online.
Chairman Cooper, we're on the Zoom call.
Let us. Okay.
We have
Okay.
Myers,
David Reiner and
Hisham.
Shaw. Okay. Do we have Mr. Myers?
Yes, ma'am. Can you hear me?
And Mr. Shaw?
1 second.
Okay. This is gonna Zoom. How do we do this?
Zoom. Try now.
Okay. Mr. Myers, are you with us?
Yes, ma'am. Can you hear me?
Yes, we can. Mr. Reiner, are you with us?
I don't believe David's going to be able to join today.
Okay, thank you.
This
And
is Natalie.
okay, and Ms. Shaw or Mr. Shaw? He was there?
No, but we can go ahead and
Okay.
start.
Okay, let's go ahead and start. Mr. Myers, if you'd like to do your presentation.
Thank you. I have a couple of other colleagues. I'll introduce Mr. Eric Chang with Quest Diagnostics, and Dr. Andrew Young are also joining me today. We'll collaborate on our conversation with you. Do you have the presentation up to where the audience can see it?
Do we?
No, they can share their screen though,
No, apparently not.
but they can share their screen.
They can share their screen?
Mhm.
I don't understand.
Is the option to share?
So Eric, you think you could share our screen?
Yeah,
Okay, we're gonna put it up for you if that's okay.
Okay. Sorry that we're novices about this.
No worries.
Okay,
how does that look?
it looks good.
Okay,
That's
great.
great. So thank you, Chairman Cooper and everyone for spending a few minutes with Quest Diagnostics today. I'm going to briefly introduce myself and our team, and we've got a rather brief conversation we'd like to share with you. I'm Alan Myers. I'm the General Manager for Quest Diagnostics in the Southeast region. And just as a broad stroke, Quest is a national company, publicly traded, headquartered in New Jersey. We run our businesses by geography, and my colleagues and I are responsible for the Southeast region, of which Georgia is very prominent and one of our key markets. So I'm joined today by Natalie Jackson, who is our Commercial Vice President for the region, Eric Chang, who is our Strategy Senior Director, and Dr. Andrew Young, who is our Medical Director for the region. So we're delighted to be with you today.
Well, thank you for
next-
doing this for us.
Oh, we're delighted to be here. Thanks for your time. So just a little bit about Quest. As I mentioned, we are a large publicly traded national company, 7.5 billion in annual revenue. Actually, we did a little better than that in 2020, but we very much are grounded in Georgia, and we have one of the largest labs in all of Quest, actually in Tucker. It's a facility that has been in the Tucker location for over 30 years and is a market leader for what we do in the diagnostics industry. We have patient service centers throughout the state. We have a vast logistics network in the state. By the way, we have 8 planes that are headquartered in Lawrence. But also over 1,000 employees, lots of doctors on call. We see about 3 million patient encounters a year. And then out of the Tucker lab, while Georgia is by far our largest market, we also service Tennessee, Mississippi, and Alabama. So that's a little bit about Quest Diagnostics, and to the right is actually the front entrance of our Tucker lab. So next slide, please. And I won't go through all the details here, but it's hard to believe that we've just eclipsed the year mark where the conversation of COVID and pandemic stretched across our state and our country. You can see along the way here, Quest has been a leader in developing the capability to do diagnostic testing, both from a PCR, which is the molecular test to detect the COVID, and the serology test, which is a detection of the antibody. So we've been leaders in the forefront of that. And Eric, if you go to the next slide, please. So just as a perspective, we shared last week to our colleagues across the company that so far through the pandemic, we've done over 31 million diagnostic tests and almost 5 million antibody tests. That's about 1 in 10 Americans have been tested by Quest Diagnostics. We currently can test up to about 215,000 tests a day. We're testing upwards of sometimes 10,000 tests a day, just FYI, in the state of Georgia. And back in the summer, we actually were doing more than that. And we actually have the capability to do this testing that we're describing here for you, actually in our Tucker facility. We're doing a lot of work in understanding the new strains and variants of the disease and how that impacts testing and also how it impacts vaccines. Importantly, not only are we doing things, I think, from a scientific and a medical perspective, we're investing heavily in areas of our country and in our state where we think people are underrepresented in terms of healthcare. We'll talk a little bit more in a few slides around the fact that there's frankly a second pandemic, in addition to folks being challenged with the COVID virus, folks aren't getting regular checkups. And we think there's a more detrimental long-term effect of that. And we'll talk more about what we Quest are doing here in a slide or two. So next slide, please. Yeah, so I talked about the fact that Quest touches about 1 in 10 Americans in terms of testing. We're moving toward 1 million tests in Georgia. We've done, at the time this was published, about 735,000 PCR tests. As I mentioned, we do the testing in our Tucker lab, but as you can see, the tests come from all over the state. And importantly, we're a market leader in terms of testing. I actually looked at the positivity rates this morning from our lab. It looks like positivity rates in Georgia are now in the mid-teens. So we were up in the 20% range a week or so ago, I think, when this was published. But the positivity rates are coming down, but still Georgia is high among most states. So next slide, please. Yep. I'd like to turn the agenda over for a little more detail around the folks we partner with in Georgia. So I'm going to turn the agenda over to Natalie Jackson. Natalie.
Thank you, Alan. And thank you for having us today. We wanted to share a little about the partnerships that we've had with COVID-19 testing throughout the state of Georgia. And many of these partners we work with not only for COVID-19, but also for their clinical testing. So you can see a lot of different partners, from pharmacies to health systems to new businesses such as Viral Solutions that have been set up to do COVID testing, and then a lot of organizations within the state. Next slide. One of the things that we also noticed during the COVID pandemic was that a lot of patients were not really going in for their routine testing, and Alan had mentioned that previously. And we've done a lot of work around tracking that data and looking into some of the thoughts from the public around why individuals were not going in for their routine visits. And we have wanted to share some of the information with you today regarding what we call back to care. And that's one of the things that we've been focused on at Quest Diagnostics, is promoting and sharing with healthcare professionals the need and helping to support getting individuals back to care. But through some of the research that we did and some of the findings, we found that 3 in 5 adults were not actually going in for the routine care that they should have been going in for. And about 53% of those individuals were concerned about COVID. And you can see the statistics there. But what we found, and Dr. Young, I'm sure, can share some additional details around this, but what we've learned through some of the health trend reporting and some of the information that we've captured is that not only are people concerned about going in for their routine work, they're also finding that because of the fact that individuals are not going in for routine testing, that cases have increased in certain disease states, cancer being one of those. And I won't go through all of the statistics here, but there are some additional facts that you can review. And again, Dr. Young will have some additional time for questions if you have those. So Eric, if you'd like to go to the next slide, please. Earlier, Alan mentioned the quest for health equity, and healthcare is very important to us, and the health of the American public is very important. And one of the things that we wanted to share with you today is Choose Healthy Life and the partnership there around focusing on the public with health disparities through the Black churches. And we partnered with the United Way in New York City, in January, and we actually set up some testing sites for COVID-19. We're also planning to do that with several partnerships within the Atlanta area. The church partners that we've selected are listed there. And this again was done in conjunction with the Black Clergy Leadership Council of the United States. So a lot of different cities we're going to be focused on and looking to reduce some of those healthcare disparities that we've seen. Last summer, we also wanted to mention that in May of 2020, we partnered with Peach State Health Plan to increase COVID testing and access to COVID testing in the underserved communities in Georgia. So as you can see, we've worked quite a bit within the state of Georgia to help to level some of those inequities when it comes to healthcare. And it's something that we're very proud to continue participating in and serving the constituents of Georgia. And Alan, I believe that's the last slide that we have today.
Well, thank you, Natalie, and thank you, Chairman Cooper. We wanted to give a brief update of what Quest Diagnostics is doing to support the COVID pandemic and what we're doing specifically in Georgia. And we're delighted that you shared a bit of your time with us today. We know you're really busy. We'd be happy to entertain questions as well.
Are there questions from the committee? Okay, anybody that's online? Do you have a question? I have one. What other diseases besides cancer have y'all picked up that people are not seeking the routine care they normally do?
So Eric, perhaps, or Dr. Young, maybe Dr. Young, you can give some feedback there.
Sure. Thank you, Alan, and thank you to the committee for this opportunity. There is much of healthcare that is contingent on regular assessments, regular visits to the physician, regular testing. One of the things that really stands out is cardiovascular care. It's important that we stay in touch with our physicians for cardiac risk factors, assessing the risk of diabetes and other related syndromes. And we have seen data that the frequency of with which patients are following up has declined somewhat in the COVID era. That, as well as, certainly cancer screening, as Alan and Natalie indicated, and a variety of other, through all age groups, all socioeconomic categories. There are a variety of syndromes where, regular visits to a physician really impact the continuation of good health.
I mean, I know that you said you were reaching out into our communities that were underserved and certain populations that were underserved. Other than education, are you talking about the not only need to be tested for COVID, but the need to get these regular assessments when they go out? When Quest?
Absolutely, yeah. We have a number of educational programs to encourage better health. We've been doing a lot of work, and Eric, I think you'd be able to speak in more detail about some of the systems that we've identified to provide information and enable people to access laboratory medicine, for exactly these purposes. And Eric, if you have any additional specifics.
No, I think that, Natalie mentioned we have a Quest for Health Equity program going on through the entire company and nationwide. And so in many ways, there are nice projects that are going smoothly, such as Choose Healthy Life, but we intend for this to be a long-term, multi-year initiative for us. And so even now, we're pulling together education materials, clinical messages that are digestible for those that are in those type of communities that are relevant to them. And so, if there are opportunities as a call to action to further get in there, those communities to educate, to deliver care, we would love to collaborate with you. Not only is there, we look at the studies and look at a couple of things offline that I probably won't be able to share with you on the screen, but Breast cancer, we see a test lag of close to 30% in some areas around the country. Sexually transmitted diseases, a very poignant and high impact gap in testing. We see a lot of that as well as again, all the cholesterol and diabetes testing and so on and so forth. So certainly a lot of opportunity. If there are opportunities to collaborate, please get in touch with us, and I'm sure we will be in touch with you as we start to spin lots of these programs up over the multi-year period of time. So looking forward to the conversations to come.
Thank you. Are there questions? Any other questions from the committee? Anybody on Zoom? No questions? Thank you very much for doing this. I mean, I think there has been questions about if we're testing like we should. I think now the emphasis has shifted somewhat, not that testing is still not important, but now it's getting the vaccines out. And that is the big push. So thank you very much for being with us and for giving us an update and for what you do. I have toured the lab late at night, 11 o'clock at night, when all the specimens have just arrived from all over the state, and seen how y'all keep them straight and process them. And it's a really impressive production to make sure how many times they are checked, to make sure that the right name stays with the right specimen. So thank you very much. And we'll look forward to working with you in the future. Thank you.
Thank you.
Thank you. Welcome. Thank you for some time today.
Okay. Thank you. Do we need to cut them off?
No, they're good.
Okay. He wants to go first?
Yeah.
Okay.
Unless you do.
No, Representative Rick Williams, you have House Bill 128. Michael's telling me that you need to go to another meeting and you wanted to present first, so you've got it.
Thank you very much, Madam Chair. Committee, thank y'all for taking the time to hear me. You probably remember from last year, we introduced Gracie's Law. Gracie's Law is named after little Gracie Nobles, who is a resident down in Middle Georgia. Representative Mac Jackson and I co-sponsored this legislation. And this legislation is to prevent discrimination against handicapped, disabled, developmentally disabled, or birth defects, even more commonly referred to as Down syndrome. This is Georgia College's book on, I only have one, but it's an article on Gracie's Law, where her mother was a nurse, having graduated from Georgia College and State University. I think a lot of you probably remember, the story of Gracie, that she was born, and at 3 months old, she was found to have some heart defects. Well, they were afraid she was going to need heart transplant. And with Down syndrome and no laws in Georgia to prevent discrimination against developmentally disabled, we found that this was a loophole and we needed to close this. Thank goodness that Gracie had a surgery. It repaired the hole in her heart. She's doing well. She's doing good. She's growing and just happiest little baby you have ever seen. She just melts your heart. And the whole idea behind Gracie's Law is to protect our vulnerable from discrimination. And we've got to see after them and take care of them. And I'll stand for any questions, but I think some other people are willing to speak on the bill also.
And this is, just make this clear for the committee, this is the bill that we passed out last year that got caught up in the end.
Yes, ma'am. Did not get a hearing over on the Senate side,
Okay.
but it was pretty much unanimous. I think just about every member of the House signed this legislation.
Okay. And we're working from LC 460360. Is that correct, Rick?
Yes, ma'am. That is
Okay.
correct.
LC 460360. Okay. David, would you like to come and testify?
Thank you, Madam Chair. I'm David Tatum with Children's Healthcare of Atlanta, and we rise in support of this legislation. Children's does most of the pediatric solid organ transplants in the state. Matter of fact, we do all the heart and liver and most of the kidney transplants. We did over 50 last year, and we have no such policy which allows such discrimination. And my clinicians tell me there is no clinical evidence to warrant such discrimination. So we are in support of this bill.
Okay. Questions for the presenter from committee members? Let's go with people here first. I don't see any lights coming on. How about anyone that is watching online? Any questions? Not picking up. Oops, here we go. Who's at 15? Who? Oh, Representative Hogan.
At the proper time, I'd like to make a motion.
Okay, and Representative Petrie.
Yes, I just wanted to make a comment to the sponsor. As someone who has spent my entire career serving individuals with developmental disabilities and others, I've seen so many individuals with disabilities who bring so much joy to their families, to their communities, actively involved in their communities. This is the right thing to do. Proud to hear we don't have a problem in Georgia today, but we need to make sure that we never do. And I thank you for carrying this bill.
Thank you very much. And on behalf of David and Aaron Nobles, they're home watching. They were here last year and had a crowd with them. And just a shout out to them that they have a lot of people back home watching this proceedings today. And thank you for your consideration, all of you. Thank you.
Okay, Representative Hogan, I think there are no other questions that we're ready for a motion.
I make a motion to pass.
We have lots of seconds. Is there any other discussion from committee members? I don't see any lights and I don't see any hands on the screen. So everyone, let's take it from here and just get used to, we'll do the people here first. Hang on, people on Zoom. Everyone in favor here in this room for it, say aye. Anyone opposed? Okay, how about on the screen? Everyone in favor, say aye.
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 Anyone opposed? Okay, the ayes have it. You have a unanimous.
Thank y'all, everybody. God bless you.
Don't
Thank you.
forget, you have to do a good job on writing up what goes to the Rules Committee.
Yes, ma'am. Thank
So-
you very much.
I'm gonna do this one first. Okay, okay, I'm gonna call and do House Bill 163, which is my bill. And since I'm gonna turn it over to, I've never had so many people want to testify for a bill. I have, but it was just great. Okay, what this bill does, when children are eligible for SNAP, which is our food, getting extra food, they also are eligible already for our Medicaid program, our Peach Care program for children. So these are children that are already eligible. They're just not on the program because they have to apply twice. And the same department, the Department of Human Services, does both applications. We are just spinning our wheels and duplicating services and delaying children from getting health care when they are eligible to have it. So what this would do would ask the state plan to be amended so that we could use, the Division of Family and Children Services could use data from other federal programs and put them together so that we could get these children qualified for both programs without duplication. This is especially important for people in rural areas because often they don't have they have logistical obstacles to enrolling. They don't have broadband or cell phone connections, as well as if they need to go to the DFACS office, they don't have transportation. So really, this is a way to help Georgia children and to also save money and duplication on state procedures. And with that, and I'm working off LC 338562S, and I'm going to call Tom Rollins to testify first. And Tom, just tell us who you are and what's your title and anything you want to say about the bill.
Thank you, Madam Chair. I'm Tom Rollins. I'm head of the Director of the Division of Family and Children Services. And this is a federal program that we have been allowed to do for some time and that we should be doing. As you rightly noted, so the federal eligibility for SNAP or food stamps is about 130% of the federal poverty line. The federal eligibility for these children for Medicaid is like 138 to 184, and then for Peach Care is about 184 to 235% of the FPL. So all these children, we got about 120,000 children right now who are on food stamps, who we could very easily and quickly add to the Medicaid or Peach Care rolls. These children would, first of all, as the chair indicated, it actually saves us a lot of time and expense. I think we've estimated back in 2009 even that it costs us about $35 per case to add a child who's already in one program to another program. So you're talking about potentially a big savings in time and labor for our folks. Probably even more so than that. These children, as I said, are already eligible. Sometimes the parents don't know about the program. Sometimes the parents just can't jump through the hoops of applying for multiple programs. If we can get these children on Medicaid or on Peach Care, think about how that will improve their ability to get preventative care, their ability to get early care, to really prevent longer term issues that cost us as the taxpayers more money and that cost them as individuals and children more healthcare problems. Think about the impact on, of course, y'all all know I'm from rural Georgia, so I always think about the impact of having more insured children in rural Georgia. It's a great, it means not only do these children in rural Georgia get health care, but it also means the healthcare workforce can actually thrive and do well and grow because they can actually get paid for what they do. So I really think this is a great initiative. I appreciate the chair bringing it, and I was very happy when I was asked to come and speak on behalf of it, and I'm happy to answer any questions you may have.
Well, I have one, Tom, and that is, I think that the other states, and there are several like Alabama, Iowa, Louisiana, South Carolina, have instigated this program. They have seen about a 6% increase in people signing up because various people have reasons. They just don't do it. They don't want to be on Medicaid, whatever reason. They've gotten insurance. So if we did that, it would be somewhere around 50, 60,000 children.
Easily. Madam Chair. And remember that, also think about it as sort of the leading edge. Folks think about needing food stamps because that's their immediate food needs. They may not think about needing to go ahead and also insure their children for Medicaid. This lets us kill, well, that's probably not a good, we're not going to say kill two birds with one stone. I apologize. But lets us get both of those programs enrolled at the same time. And I think is a really good use of, think about we send our tax dollars out of state to the feds. This will also help us pull back down those dollars for our children.
Because a large portion of it will be paid by the.
Yes, ma'am. About 67 cents on the dollar is paid for by the federal government.
Okay. So, well, and the nice thing about it is children basically usually are low users.
Yes.
Have healthcare, but when they need it.
When they need it, they need it. And I think we have some other folks going to talk about, especially like the early behavioral health care interventions that really help our children from becoming, we're keeping them out of foster care. We're keeping them out of the hospitals. We're keeping them out of the juvenile justice system by both addressing their physical and their mental health needs. So it really is a wonderful prevention measure.
Representative Petrie, do you have a question for Tom? Got it.
You got it. And Mr. Rollins, thank you for being here. And I appreciate all your help through the years with constituent issues.
Yes, sir.
You're always a tremendous help, and I appreciate you for that. I wanted to make sure I understood you. Did you say that there are currently 120,000 children in Georgia getting food stamps that are not on Medicaid
Or peach care, yes, sir.
that would likely, that would likely qualify?
That's correct. Now, some of those
Okay.
children, of course, may have other sources of Medicaid or other medical assistance. They may have SSI. They may have some private insurance.
Okay.
So, but we're talking about a significant number of children who could benefit.
That was what
Gotcha.
I was
Thank
talking about, Representative Petrie, is that the other states that did it saw a sign up of about
6%,
6%, which is about 50, 60,000.
Interesting. Yeah. Thank you, sir. Thank you for
Yes,
being
sir.
here.
Sure, thank you.
Okay, other questions for Tom? Okay, oh, we have one? Okay, Representative Sharper?
Thank you, Chairman. Thank you for being here also.
Yes, sir.
But mentioning, about the economics involved, would a fiscal note be necessary?
No,
Okay.
I mean, we have to get a plan adaptation before we can even consider doing this.
Right.
Okay. Okay, I was just wondering.
Thank you.
And these children are already eligible.
All right.
And there's programs out there. I mean, we're paying money for programs to try to reach these kids that are very expensive, when having the dual system would be much more efficient than what we're paying for to go out and enroll them, which isn't always doing a really good job. I mean, I mean, it's just hard to find people. It's hard to get to the right people who have these children, and they are already eligible
They are.
to
And-
be on this program. So it's not really expanding in it. It's just getting to the children that are already eligible to have it. And these are some of the poorest of our poor children.
Yes, ma'am.
All right. Other questions for Tom? Do we have any questions from people on the Zoom meeting? Can you tell me? No, we don't have any. Thank you, Tom, and thank you for, Representative Hogan, you do?
And most of these children, thank you for being here. Most of these children are rural children.
I can't say that most of them are, sir, but I do know that, as we know, because of, as I think Chair Cooper may have mentioned, some of the broadband issues, some of the access to the getting the sign up for the various services. I'm coming from a rural perspective. I think you'll see that these children are all over the state. I think from my standpoint, this really is something that is especially good for our rural children, because it does meet a significant need. We have so much that we need to do in terms of building our healthcare infrastructure in rural Georgia, and I think this goes a long way towards that.
Madam Chair, at the right time, I'd like to make a motion.
Okay. And I will say that one of the problems that we are facing, and Tom would certainly know, I mean, Tom, how many children do we have in state care now?
We have 11,200 as of today.
Isn't that a lot higher than it?
Well, it actually has gone down, but Madam Chair, I think one of the things that we have noted, and this is another thing I want to just reemphasize, is that we do have children who come into our care because they aren't getting the medical or the behavioral health care that they need. And so anything that we can do to make sure that they are getting that care and are insured, that's going to further reduce the number of children who have to be in state custody.
Well, the other thing I worry about is now that when we don't have children in school, our school teachers are one of the places where we pick up child abuse.
Yes, ma'am.
At one of the top places that we do. These kids are not, and as stress rises in these families, and when they're faced with money and not being able to care for their children, often it's taken out on the children. And one of the places that is a backup to the schools is when a mother takes a child and the doctor sees for a cold, and the doctor sees bruises and other evidence of abuse and is able to intercede. So it's sort of a twofold thing about taking care of these children.
Yes, ma'am.
Okay, Don. I'm sorry, Representative Petrie.
And I'm sorry to belabor the point, but as you're speaking, there's a story that I wanted to just tell briefly to that point. It's so important that we protect the most vulnerable in our society, and certainly none more than children. I was reminded of way back in the day, long before my current career, I worked briefly at the health department and in environmental health. And we had a full-time employee at that particular time whose job full-time was to call mothers with children who had not been immunized yet. You'll be familiar with this. And over and over and over. And I had a good relationship with this lady, and she would literally beg mothers to bring their children in to be vaccinated. And so sadly, not every parent does the things they need to do to protect their children, as the chair lady was speaking to. And so to me, what we need to do is certainly minimally what we can do is make sure that there aren't barriers there to keep children from getting the health care they need. We need them to get it any way they can get it. But that was a very powerful story to me, because to me, I couldn't get my head around the notion of having to plead with people to bring their children in to do something that they knew was best for them. So my mindset is we don't need barriers in any way, shape, or form to children getting the care that they need. And so I just wanted to make that point.
Thank you.
Well, and I think that we passed the bill and we thought all eligible children, were already in peach care, and we were taking care of all these children across our state. And we find that we're not, because of the barriers that you talk about, Representative Petrie, and this would remove one of them and give us a chance to see if we would be like the other states and pick up 6% or however. And like I say, we're paying a lot of money to try to reach out to that. And I don't think they've always been real successful for various reasons. I'm not casting, negative thoughts about our state employees, but I just think for various reasons, it's often not as easy if all of a sudden you need food stamps and you also realize you can get your child care. Okay, Representative Hogan, you are recognized. Oh, wait a minute. Wait. We have lots of people that want to talk or testify about this bill. Okay, start with David Crooker. Online?
Yeah, good afternoon. Can you hear me?
Yes, will you tell us who you represent? And
Yes, ma'am. I'm David Crook, and I represent Care Partners of Georgia. Care Partners is a children's behavioral health organization located in Swainsboro, Georgia. We serve Emmanuel, Bullock, and Candler counties, and we work primarily with children, youth, and young adults. And I stand in strong support for this bill, because I think it would greatly enhance access to needed mental health services and also medical services for the people that we serve. We roughly serve 500 to 600 children and youth each year. And one of the things we've noticed along the way is that, as you said, Madam Cooper, there are multiple barriers that stand in the way oftentimes from children and their families to be able to apply for Medicaid services. And I think in particular about some of the situations where these situations arise, and they typically arise in situations where in rural Georgia, we have a number of grandmothers and older relatives that are having to become surrogate parents for their grandchildren and their much, much younger children. And oftentimes, as you said, transportation is a barrier, technology is a barrier. There are just multiple barriers that keep these older folks from being able to apply for SNAP services, food stamp services, and Medicaid services at the same time. So I think by eliminating this one barrier, it will really enhance access to care. And I think that can go a long way in rural Georgia, because one of the big issues we have in rural Georgia for not just mental health services, but for all healthcare services is access. So I think, this could really speed that thing up, speed the situation up, speed the process up, and can really be a great service, not just for children, but for their family members as well. So I'm in strong support for this bill.
thank you very much for testifying. Mrs. Boyker?
Bucard, Jasmine.
Hi.
Hey,
I'm sorry if I mispronounced your name.
that's okay. Good afternoon, Madam Chair and members of the committee. My name is Jasmine Bucard with the Children's Healthcare of Atlanta Government Affairs team. I'm here today to testify in support of House Bill 163, Children sees more than 400,000 unique patients in a year, serving all 159 counties in Georgia. In 2019, approximately 58% of our unique patients were on Medicaid or Peach Care for Kids or unable to cover the cost of their care. So children supports making sure that every child has access to healthcare. Streamlining the process for enrolling kids in Medicare will ensure that they get that access. So thank you very much, Madam Chair, for bringing this bill forward, and I'll turn it back to you.
Thank you very much for your testimony. Laura Colbert.
Hello, I'm
Hello.
Laura Colbert. Hi, you guys are getting better at this already, and you'll be experts in a snap.
I don't know about
Well, I'm Laura Colbert. I'm the executive director at Georgians for a Healthy Future. We advocate for affordable, accessible, quality healthcare for all Georgians, including children. And there are few better ways to foster a healthier future for our state than making it easier for kids to get and to stay enrolled in healthcare coverage, especially Medicaid and Peach Care. The data says that kids covered by Medicaid go farther in school, that they're healthier as adults, and that they're more economically successful in their adult life as well, and than those who are uninsured or inconsistently insured. So HB 163 would bring these benefits to an additional 60,000 kids in our state. This move really meets the needs of families, especially during the pandemic when there are so many demands on their time and attention. And it also streamlines the government services and systems. So we believe this bill is a true win-win. We are very supportive of HB 163. Thank you to Chairwoman Cooper for your leadership on this, and we urge the committee's support for the bill. Thank you.
Oh, you're welcome, Laura. I mean, I can't take total credit for it. When I do classes or talk to people about the legislative process, I say that ideas for bills can come from anywhere. And Polly Mckinney and I were just having another conversation about something else. And Polly went, "Oh, and did you realize that this was a problem?" And I went, "No, I did not." So a lot of kudos to Polly for also just, in a conversation, bringing this to my attention of what a problem it was. Callan Wells.
Yes, thank
You have
you.
a question? Wait a minute, we have. Huh? Can we go back to? Okay, Representative Howard, you had a question? Pardon, sure. Or you don't have one?
Yeah, that's fine.
Go ahead.
My question is, I'm happy to see this happen for the rural counties and the rural cities. Excuse me. But does it, if Tom or someone will have some numbers on inner city kids, what do those numbers look like?
I don't know that they're broken out by, we can probably get that for you.
Okay.
Okay, Polly can probably. Okay, I think Tom has it as his fingertips.
Via Polly, of course.
Via
Madam
Polly, of
Chair.
course.
I don't know if, I believe Polly handed out this, and this kind of gives us some uninsured rates among children by county. It's it's the back of the second page of this handout. And if you would like actual numbers via, like, for example, in your district, I'm happy to get those for you. Kevin is here and we can do that for you. Okay. But again, I did emphasize rural, but we are talking about children all over the state.
Thank you, Tom. Oh, okay, Callan. Ms. Wells, go ahead.
Yes, thank you so much for allowing me to speak today. My name is Callan Wells. I'm the Health Policy Manager at GEARS, the Georgia Early Education Alliance for Ready Students. We are a statewide research, policy, and advocacy organization that works specifically on issues affecting children 0 to 5 years old. Today, I'd like to express our strong support for HB 163. Georgia has an extremely high rate of uninsured children. Currently, 7.2% of Georgia's children are uninsured. While 39% of Georgia's children are covered by Medicaid, it's estimated that 12% of children eligible for Medicaid are not enrolled, contributing to our state's high uninsured rate. This affects Georgia's youngest, most vulnerable population. Only 62% of our state's 2-year-olds are up to date on all recommended well child checks, and only 72% are up to date on immunizations. These data are from before the pandemic, and we anticipate these numbers will only get worse. Ensuring children have continuous access to healthcare through Medicaid and Peach Care by implementing Express Lane eligibility will help. Alabama implemented Express Lane eligibility several years ago, among other enrollment strategies, and the uninsured rate among Alabama's children is now less than half of ours at 3.5%. So we strongly support members voting yes on HB 163. And again, thank you so much for your time.
Thank you very much. And surely we can do better than Alabama. With all due respect to Alabama, I'll probably hear from one of the legislators over there about me making that remark. Okay, Polly McKinney, would you like to testify?
Sure, I'll speak for a moment, although I think y'all already know what Voices for Georgia's Children thinks about this bill. I just want to let you know that if you want to feel even better about this legislation, well, first of all, I'm Polly McKinney, Advocacy Director at Voices for Georgia's Children, and we cover pretty much all children's issues. And thank you, Madam Chair, for bringing this bill. And thanks for the shout out. Also, just so you guys can feel even better, right in 2019, before COVID, we had 197,000 children who lacked health insurance, many of whom are Medicaid eligible. And as many people have said, this will capture an awful lot of those kids and help them get health care. And the one other piece that I haven't heard mentioned yet is that when children's Medicaid expires, a lot of them roll off and then they have to reapply. And we think that this dual enrollment process will help those kids not roll off and keep continuity of care. So if they're on chronic conditions, they can keep on their meds. They don't have to worry when they show up at the doctor's office. So, and I'm happy to answer any questions. Is there any left?
Any questions for Ms. McKinney? Okay.
Thank you so much.
Thank you very much, Ms. Count. Okay, Betsy Bates. Is that it?
Good afternoon. I'm here today representing the Georgia chapter of American Academy of Pediatrics. And I think you've heard a lot of this bill in detail, and I just wanted to add the chorus of our support for this bill. And thank you, Madam Chair, for bringing this bill and taking the leadership to help Georgia's children succeed in life.
Thank you.
Thank you.
Okay, that is the end of our questions. Since this is my bill and I don't want to have any undue influence on your vote, I'm going to turn it over to Mark, my vice chair, Representative Newton, to call the vote and all. Go ahead, Mark.
Thank you to all the presenters and to the author in particular for this bill. We'll entertain a motion at this time. All right, we have a motion do pass. Is there a second? Is there any other discussion? If not, all in favor say aye. Aye. Any opposed? Nay. The bill passes.
Well, you need to ask about the Zoom.
LC 338562S is what the one we're voting on. And let's ask for at the votes on Zoom. All in favor, raise your hand. All right, there we go.
Okay.
Any opposed? Raise your hand. All right. I think we have a strong do pass. Thank you, Madam Chair.
Thank you very much to members of the committee for that vote. Okay. Let's see what we got next. Let's go to Representative Gaines. Is he here? Oh, sorry. Houston was sitting back there being so quiet. Representative Gaines is bringing House Bill 146. Okay, and the LC number on that, Representative Gaines?
The LC number is LC 364525.
Okay.
And I'll be really brief because this is the same bill that this committee passed out unanimously last session, and then the House passed it 164-1. And the one no vote is no longer here. So I feel like we have strong support in the House. But I'd ask for your favorable consideration. Ensures 3 weeks of paid parental leave for state employees, including our teachers and educators. Happy to answer any specific questions, but again, this committee's already seen this bill, and so is the entire House.
Question for Representative Gaines. Representative Jones.
Thank you. I have a question. How did you decide on 3 weeks?
That was the timeline that we felt, that we could get past, and that we felt like we had strong support for, and that was what we worked with agencies and all the stakeholders on, and came up with the 3 weeks of paid leave.
I have another question right here. Will you consider changing the 3 weeks to 6 weeks, something higher than 3 weeks?
Sorry, there you are. I thought you were on Zoom.
Yeah, that's why I waited.
I know, I'm like, this whole Zoom virtual thing. Another piece of legislation, I think that, be happy to look at. I do think we should, in order to get this bill passed and to get something on the books, I think this is where we should start.
So do you don't, another follow-up question?
Sure.
You don't think it will pass with 4, 5, or 6 weeks?
I want to do something that we can get passed, and I feel confident we can get, last year, the Senate, we weren't able to get this bill over the finish line in 2020. So I think that, if we need to get started, and I think that 3 weeks is where we need to be for this bill. And I'd be happy to support another piece of legislation looking at further weeks, but I think that in order to get something on the books, this is where we should start.
Okay, thank you.
Representative Mitchell.
Yes, Madam Chair. Representative Gaines, was it 3 weeks last session?
It was.
Yeah. As the American College of OBGYN recommends 6 weeks. Madam Chair, I think with your support of 6 weeks, this would fly through the House.
Thank you so much for thinking I'm Superwoman.
Oh, because 3 weeks, in light of the fact that the American Academy recommends 6, somehow seems inadequate. As a matter of fact, as you may know, South Carolina is debating as we speak 12 weeks.
Well, and I don't disagree that we could get it through the House, but what I'd ask is do you want anything on the books, or do you want 3 weeks? And I think by that proposal, we're going to have an even more challenging time in the Senate. And so I'd ask for the House to stand together once again. 164-1 last year was the vote. And so, for me, I don't know why we'd be trying to make this change when we need to get something done. And I think this is an important step forward for our state. So I'd ask for us to pass House Bill 146 as written.
Dr. Newton, Representative Newton.
Just to follow up on that, because I do think the 6 weeks is clearly a recommended. There are a lot of these individuals may have short-term disability policies. I know there's family medical leave, which is unpaid, just keeps your benefits. I think it would need a little bit of evaluation to find out. I know it includes teachers,
that's right.
and all state employees, many of which may have some short-term disability, which can be added on. And so I think to put it all together, I'm sure it's going to be more than just 3 weeks with pay. There's more time off, but then there's also the potential, I believe, for another 30 days of short-term disability. Some, depending on the conditions, it can go up to 90 days for some of that. So I think it's wise to start with something and then piece them together, and then let's find out where the gaps are, and then come back and look at it again. I think that would be a wise course for this body.
And I'd be happy to, again, on another piece of legislation, try to look at something that 6 weeks or whatever the number may be. But let's get this done and help our teachers and our state employees and new families across this state who as we introduced this bill last year, over the last several months, one of the neatest things that's happened to me since I've been elected is getting pictures of families that are starting and the impact that this would have on their lives. And just a couple days ago, visited with a state employee in an agency, and they walked me through how this would positively impact them. And so I would just ask for a favorable consideration and of this bill. I think it's a positive step forward.
Okay, Representative Hutchinson.
Thank you, Mrs. Chair. I have a question about the foster parent aspect. Some foster parents are, like, for lack of a better word, transitional, and they can get children all once a week. So how does this affect those people who might get a foster child, twice a month, once a week?
Sure.
They can
The
take the
benefit
whole
is
year
limited
off.
to one use in a 365-day period.
Thank you. Representative Schofield, come on back on the screen.
I'm here. Thank you, Madam Chair. I have a question. Thank you, Representative Gaines. I have a question, just two quick questions. Why was the choice made not to include paid medical leave in this bill, especially at a moment when COVID-19 continues to do such harm and highlights the immense need for further support of workers to reduce the risk of public health and the economy?
Again, be happy to look at that in a different piece of legislation, but this is what we were able to get through the House last year. And again, I think there's a positive step forward, but any other piece of legislation you want to work on together, I'd be happy to look at it with you.
Right, but follow up, Madam Chair, but last year was one thing to get something through, but things change. We have COVID. So why not go back and relook at this legislation to match the needs, the true needs of where we are now, as opposed to where we were back then? It would have worked last year, but it's not going to work going forward. So
you don't support 3 weeks of paid leave for state employees? Is that what you're saying?
yeah, let's go back. I mean, at the moment when COVID and you're taking out this medical leave in this bill, I just curious. Why wouldn't we go back and put in what we need?
Again, I'd be happy to look at that in a different piece of legislation. We didn't take anything out. This is the same piece of legislation that we more or less passed last year. It doesn't take anything out of the bill, but be happy to look at another piece of legislation with you on the issue you brought up. But again, I think this is a really positive step forward for new families across our state.
Last question, Madam Chair, and then I promise it'll be the last one. But I in looking at this, because this is something I've worked on paid medical leave before and paid family leave, but the research says that this actually would help in retention of valuable employees if we had the 6 weeks and decreasing the cost of turnover. I mean, how, since this is maybe a private sector employees for generous benefits already in place, do you view that the policy that we have now is a great investment for the state?
Well, currently we don't have any paid leave on the books. So our current policy is what I'm trying to improve on, and by adding 3 weeks of paid leave. So I think that this would be a significant improvement on our current law, and that's why I brought the bill forward.
I'm sitting here listening to the discussion, and it's sort of like what we had on maternal mortality. In the perfect world, we would have extended out to a year, but it's not a perfect world, and we have to be able to get things through on the other side, and we have to be able to pay for them. And sometimes when you bite off a great big huge chunk of something, you choke on it. And I think that that's what Representative what Houston is trying to tell you and to explain to this committee. He's afraid that if we move to expand this, we will just put a death toll on it moving forward. Representative Hawkins.
Thank you for bringing this legislation once again. I echo the chairman and the vice chair. I think 3 weeks is really not a long time. I mean, I could see the need for 6 weeks, but if we expand this to 6 weeks, someone's going to call in question a fiscal note somewhere along the way, possibly, especially on the other side of the Capitol, which they would be in their right to do. So I agree with you. I think the committee should vote this 3 weeks. Let's get this on the books, and if we can get more later, that's fine. But I think we need to move this bill now.
Thank you.
Representative Sharper.
Just looking at this, I don't know if there need to be some type of clarification in this, but if you're saying that, we're going to do the 3 weeks, but if a person have other sick time built up already and they need the 6 weeks, they can get this 3 weeks and their other 3 to make it 6. So they can have what they want and still be covered. Is that right?
That is true. And that's in the bill. Yeah. So it does talk through and different agencies. It leaves up to agencies for writing the rules in their different departments and agencies, but that is discussed in the legislation.
Exactly. And I think, the bill, the 3 weeks, I understand what someone's saying about the 6 weeks, but still, if you've been working for a while in the company and you got, some of these things come up, you still have your personal time and your sick time that you can add with the
That's
three
right.
to stretch it out. And some of them even longer, just depends on how long you've been working there. So this is doable. And like you said, if we need to do it, we do it and they can still use what they need. So I think this is the right direction to move with this to get something going. And this really helps, the families and the different things that we're trying to do here.
Thank you.
So
I appreciate
support
that. Thank you. Thank you very much.
Representative Newton.
At the appropriate time, I'd like to make a motion.
I don't see any other questions from committee members. Oh, we do have Representative Hutchins. At the proper time, I'll make the motion. Representative Hutchins, wait. Okay.
I must not have taken it down from the last question. I'm sorry.
Okay. All right. It's proper time, Representative Newton.
I'd like to make a motion do pass.
Okay, we have a motion to pass in a second. Is there any other discussion? I'm seeing none. Everyone in favor here that's in present here, say aye. Aye. Anyone opposed? No. Okay, the ayes have it. Let's go to everybody on Zoom. Everyone in favor, raise your hand. Okay, anyone opposed? No opposes? It passes. Thank you very much to everybody for that one. Okay. Okay. Last but not least, do I have Joe Wood here? I mean, Joe Hood. Joe Hood. No?
Hi, Madam Chair. Madam Chair.
Oh, there you are. Okay. Hi.
Hi, how are
Haven't
you?
seen you in a long time.
Yes, ma'am.
So, okay, just wanted to make sure you were here. Okay, this is another bill that I have. It's basically, can I call it a department bill?
Yes, ma'am.
Okay, it's a department bill. And here again, it is trying to get rid of duplicate regulations that we don't need. What the bill does would remove requirements for laboratories that are already subject to federal oversight to obtain a separate state licensing. And this would eliminate the state having to do very burdensome paperwork and on-site inspections when they don't really add any significant safety or quality to the value of the regulations or the laboratory. So we already have federal regulations in place, and this would just cut out the duplications. The laboratories would still have to report testing results for infectious diseases to the Department of Public Health, and would allow DCH to take enforcement actions against any laboratory in Georgia that operates without appropriate federal CLIA certification or waiver. A majority of the states do it this way, 28, we would be 29, and they don't require a separate licensure. And in Florida, removed their requirement for a separate licensure in 2018. So I'll be glad to take questions, or Joe is there with the department and he'll be glad to discuss the bill if anybody has any questions. Okay, well, hang on just a minute. Okay, Joe, would you like to add anything to that?
No, ma'am, I think you did a great job. I mean, that's what we are changing licensure and removing that from state statute, which is the duplicity. And we would retain certification. The department, through the Health Facility Regulation Division, have a contract with the Centers for Medicaid and Medicare to do oversight for certification, which is the separate certification all labs are required to do. And this legislation just removes licensure and replaces it with certification for enforcement actions as you described. And appreciate you bringing it. I'm happy to answer any questions.
Okay, are there any questions for Joe? Okay, Dr. Newton.
Thank you. I appreciate the bill. I think the first three sections, which seem to deal mostly with the lab, seems most appropriate. There is one thing in section 4 that has that I have heard some concern about is testing, some increased testing that the FDA may allow or that would be done at a pharmacy. And then the pharmacist, rather than necessarily being able to follow up with the patient and explain what they need to do, it looks like they will make an effort to report it to the physician who may not have seen the patient about whatever the condition is. And then I know there's some immunity in here, or at least something about liability is limited. But I know I've heard some expressions. I don't know if anybody from the medical department is here to discuss it, but I know the concern of having someone else have a relationship with a patient, of doing a test, of getting a result that needs some follow-up. And then instead of being able and having arranged in advance to do that follow-up, for lack of a better term, dumping it on the physician's answering machine and saying, hey, this potassium was dangerously high. Good luck. I don't know. I'm just here seeing that section 4, which seems a lot different than all the lab clarification that's in the first 3 sections.
Okay, we have somebody, Greg Roth's here from the Pharmacy Association. Greg, could you come forward and talk to that?
Thank you, Madam Chair, and Dr. Newton, I appreciate your question. Definitely, as you read it, I think it has the potential to get a bit confusing. I would first point you to page 10, lines 228 to 234, because in sort of removing a lot of this, I would say, redundancy with sort of federal CMS requirements, what it also does is it removes this section that exempted pharmacists out of Georgia's Clinical Lab Act when they were conducting tests that were approved for home use. And so, for example, think, the oral swab HIV test that's been approved for home use. There are some, drug tests that have been approved for home use. And so in 2018, we worked with this committee to include in the Clinical Lab Act an exemption for pharmacists doing at-home tests. And in that, we had worked with all stakeholders, and we said, hey, pharmacists are going to make a good faith effort to report that to the patient's physician of choice. And so what we now do, since that section is being deleted, we're trying to preserve the pharmacist's ability to perform at-home tests. And so in so doing, we think that really we improve upon this language to protect physicians. And so if you go to page 19, between lines 459 and 470, it essentially is quite in keeping with what was an existing law. We tighten up a little bit because originally it was available to and for use by the public. Well, this tightens it because it says it has to be cleared or approved by the Food and Drug Administration as a home use test. So we have that in there. And then on top of notifying the physician, what we've done is we provide some liability protection for physicians so that it doesn't require the physician to act. And, we had talked with the Medical Association about that. And, I got that there's some concern. Hey, if there's a positive test and a pharmacist provides it to the physician, does that somehow put the physician on the hook to act? And so what that language there does is it clarifies that it doesn't and won't incur liability for the physician. So this section is very in keeping with what was an existing law in the Clinical Lab Act. We're just moving it and we're adding some additional protections for physicians. There were some other discussions about the potential of adding COVID testing. It was opted not to do that. I suspect that may be sort of some of what you were hearing. But this is preserving the pharmacist's ability that exists in the law today to help patients administer and interpret tests that have been approved by the FDA for home use. And there's, several of those tests.
Dr.
I guess my concern with clarifying it like this, first off, we're taking it out of Georgia's hands and we're putting it on the FDA, which is fine. If it's approved for home use, I would prefer the person doing the testing or the entity doing the testing, they're a medical professional that wants to do home testing, is just communicate it to the patient. You're taking care of the patient, communicate it to the patient. I think leaving it on the doorstep of a physician practice that had nothing to do with the selling of the test, the performance of the test, but now has at least an pretty strong ethical obligation to somehow take over. I look at it and would say if it's a home test that the patient could have done at home and gotten their own personal result, I'd say if y'all want to take over doing that for whatever reason, the patient wants you to help with it, I'd say report the results to the patient, and patient is welcome to bring their results to the physician office and ask, but I think this leaving them on a fax machine or an email or an electronic medical record, I mean, I get it all the time in the emergency department after hour call about a potassium that's 7.1. And now, but there is no, yes, they are my patient officially, but we've got to scramble and try to figure out where in the world this person is. And I just would love to see that section modified a little bit more.
Yeah.
If you're going to establish that relationship with a patient that includes testing and results, follow up your own testing and results.
Completely appreciate that perspective. And I certainly don't think we would have objective to it. I would note, it is in the existing law that the physician has to be notified. And so what we were trying to do is add kind of an extra layer of protection by saying that there should not require any responsibility on the part of the receiving physician, nor shall a physician be liable for failing to take action after the receipt of the results. So I would propose this is certainly adding some protection for physicians, but I defer, right? I completely get your point as, hey, maybe it doesn't need to go to a physician at all. It should go to the patient and let the patient handle it as the committee wishes there.
Betsy, is there any way to delete part of this?
You can take out that whole sentence.
Which?
Yeah, it'd be fairly easy.
Starting where?
Starting on line 461.
Yeah.
Down to line 465.
Okay. Do you want to make that as an amendment, Representative Newton? Start at 461.
Right. I guess, yes, I would move that we eliminate, starting with a pharmacist on line 461, wherever she said, down to the end of
465 and
465. I'd make that amendment.
Okay. We have a motion and a second. Okay. Let's go to see what we get on the bill. This is a substitute. I'll go ahead and do it since you're the substitute to House Bill 93. It's LC 338600S. We're going to take up the amendment, but let's see how we stand on the bill. What? We need a motion. I'm trying to get a motion on the bill.
I move do pass.
Right, on the bill. We
On
got a
the bill.
motion do pass and we've got a second. Okay, now let's go. Is there any other discussion on the bill before we move on that amendment? Okay, we have an amendment that on page 19, on line 461, starting with a pharmacist and going through 465 and ending at the beginning of that sentence after a pharmacist, that be eliminated. Okay, we had a motion and a second. Is there any further discussion on that proposed amendment? Okay, hearing no discussion. Everyone in favor of the amendment, say aye.
Aye.
Is there anyone opposed? Okay, is there anybody opposed over here? Are y'all in favor of it online? Where we have no, okay. And no one's opposed? Okay, the amendment passes. And now for the bill. Everyone here and present that is in favor of the passage of the substitute to House Bill 93, say aye. Anyone opposed, no. And we go to people on Zoom. Everybody in favor of the passage, raise your hand. Okay, anyone opposed? We have no, okay, and the bill passes. Thank you very much. And that is the end of our committee meeting today. Thank you very much. I can't believe it. We're out 4 minutes early. Thank you.
Next time, tell me